morning. Hello everyone. Thank you very much for coming this morning. It's great to see such a fantastic turnout, particularly at this time of day. And I really appreciate the opportunity that you've all given me to present what we've been doing. So by way of introduction, my name's Todd Fraser. I'm an intensivist and retrieval physician. And to sort of highlight and begin this discussion, I used to run an intensive care unit, as some of you will know, and I've run a large base for a metropolitan helicopter retrieval service as well. And it was there that my interest in the way that we go about business in healthcare evolved. And to highlight why I started along this journey, I thought I'd relay a story to you. So about 10 years ago, I was working in the intensive care unit in a small regional town in Queensland. And it was a Saturday afternoon just before Christmas. We had a patient who had had a complicated laparotomy, had gone into renal failure and needed to have a VAS cath inserted so she could have dialysis. I was working with a fairly talented registrar at the time. She was great. She was from England, over as they all do. We're over on a working holiday for 12 months. She's very interested, very capable. And I asked her to put the VAS cath in. And she went away and diligently got herself set up, and the patient was ventilated, so she was covered up with all the drapes. And then all of a sudden, the patient started to get quite agitated, and this registrar had said she'd had a bit of trouble in getting the VAS cath in, had come out again and then had gone back in again, and it seemed to be going okay. And then all of a sudden, the patient arrested. And we worked pretty hard on her to try and work out what was going on. We weren't sure whether she'd had an air embolus or whether she'd had a pneumothorax or what was going on. About halfway through the resuscitation, we realised what had happened. She had a chest full of blood. She had a big haemothorax, and we didn't really know why, but what transpired is that as the registrar was putting this line in, she'd punctured a major vein in her neck, which had caused bleeding into her chest. And she effectively bled out. And we worked on this patient for about 45 minutes, and eventually, after calling in all the resources, surgeons, etc., putting chest drains in, doing everything that we couldn't get her back, and I had to say, it's time to stop. And the registrar was standing at the top of the bedside at the time, managing the airway, and she'd been holding it together really well for that entire period. But the moment that I said, we need to stop now, the look of devastation on that registrar's face is something that I'll never ever forget. The next conversation that I had was just as memorable for very unpleasant reasons when I walked in and spoke to the family and told them what had happened. And they listened very quietly, and then one of them stood up and said, "So what you're saying is that you killed my mother?" And I had to respond, "I think we did, yes." And that's another face that I'll never ever forget. Now, in the wash up from an incident like that, you inevitably sit down and you talk about all the things that possibly could have gone wrong or how you could have changed the course of something like that. And inevitably it came up that we had to ask the question, did we know that that registrar was capable of doing that procedure or not? And while I still believe that that registrar was very capable, I can't definitively say yes or no whether she was able to do that procedure, because we don't document, we don't rigorously put those processes in place to make sure that our staff are properly trained. And that got me thinking a lot about this issue, and that's where Osler was born. So today's an opportunity for me to present this to you. We are now a commercial entity, and we've implemented this in 3 hospitals. The first 2 were in nursing environments, even though the nucleus of all of this, as I just described, is in my experience in the medical side. But to present to you as a senior group of nurses throughout Queensland is a great opportunity for me to find out what your thoughts are about a platform like this. And secondly, it gives me an opportunity to let you know what we're doing and see what your thoughts are. So here's the problem that I see. I think we're not quite as ready to execute as we think we are. I'll give you another case example. So not all that long ago, I was called into another ICU and asked to intubate a patient. This patient had been in the ICU for about 12 hours and had bilateral pneumonitis and was getting worse and worse very quickly. So we had a bit of time to prepare. But I was out of the hospital at the time. I asked people to set up. Got into the hospital and found that nothing had been set up because people weren't quite aware of the things that needed to be done. While we sort of rummaged around and I gave some directions, I asked for the capnograph to be set up. So for those of you who don't know, the capnograph is an important tool that we use that can detect carbon dioxide in expired air. So as soon as you put the tube in, you connect the capnograph and you see a nice reassuring waveform on the screen, which confirms that the tube's in the right spot. Makes me feel much more comfortable when that happens. So I asked for the capnograph to be prepared, ready to go. The nurse very diligently said, yep, no problem, and went about that business while I focused on some other things. We put the patient off to sleep, got the tube in. It was very difficult. It wasn't as easy as anticipated. And because the patient had terrible lungs, they dropped their SATs to almost nothing, which was frightening for everybody. And so made that, because I wasn't 100% sure that tube was in the right spot, and I was worried about the SATs being so low, it became even more important that we had that capnograph. Of course, we hooked it up and it didn't work. And to cut a long story short, the reason for that was that it hadn't been set up properly. We then had the patient x-rayed, so we got it in finally. We were comfortable that it was in. We got the wardie in, who threw the patient over on their side so that the x-ray plate could be put under their back and threw them back over onto their back again. In the process, dislodged the IV that was running the sedation and managed to extubate the patient in the process. Awesome. We then corrected those two deficiencies in our process and we got the x-ray. We then took the patient off to the CT scanner. The inotropes that were keeping the patient's blood pressure up ran out halfway through the exercise. We got the patient into the CT, plus inotropes, put them through the CT scanner and the transport monitor started alarming. And the nurse who was looking after that side of things didn't know how to troubleshoot it. We then got the patient back to the mothership, plugged them back in again, and we talked about what had just happened. And we found that the nurse who was looking after that patient hadn't looked after a ventilated patient for about 2 months, and nobody knew. And you look at every single one of those things, and if we had realised that those things were problems beforehand, we could have done something about it. Now the patient did okay. They were extubated, went home, did very well. So all of those incidents were effectively near misses. And because they're near misses and they didn't end up like that registrar's patient up in that regional ICU, nobody did anything about it because nobody thought it was important to. And we've missed a series of opportunities to improve the way we do business. Now, sometimes things do go wrong. And frighteningly, they go wrong more often than you might realise. There's estimates that in the US, about 200,000 American patients die every year because of potentially preventable healthcare error. 200,000. So when you put that into context of another industry, that's the equivalent of 2 Boeing 747s crashing into the ground each and every day. Now you have to ask yourselves, what on earth would happen in the aviation industry if that actually happened? If we had 3, let's say it went on for 36 hours and we had 3 747s crash, what would the aviation industry do? They would shut everything down, they'd investigate and so on. They'd find a solution to that problem because it's bad for business having people fall out of the sky. But you have to ask yourself, why don't we notice in healthcare? And I think there's a combination of factors. There's no doubt that a big ball of flame is spectacular. If you take out 350 people simultaneously, it makes news. But when one patient dies of sepsis on the wards because we didn't do aseptic technique properly, what happens? Nobody even notices. Things happen distant from the action. If the pilot stuffs up, they die. But if we stuff up, we go home and the patient dies 2 weeks later, potentially. So there's this insidious nature of error in healthcare that we don't even notice is happening, and we can't, there's no way to join up the dots so that we can take personal responsibility as an industry, for these errors. But it's a big problem. Now, not all of those incidents will be related to what we're talking about today, which is being prepared and being trained appropriately for task. But certainly a large, substantial number of them are. And in fact, in Queensland, when you review all of the coronial inquests and SAC1 incidents that have been reported over the last 10 years, about 50% of them relate specifically to errors in training and education. Yet training and education is often the first thing cut from the budget, as many of you will know. So here's a question, what does competency actually mean? Does anyone have a good definition for competency? When we say that term, what do you mean? Has anyone thought about that? When we talk about competencies all the time. And if you look it up in the dictionary, which of course I did, it says in the Oxford Dictionary, the ability to do something successfully and efficiently. It's not a bad definition. But that's very hard to measure, isn't it? How do you define successfully and efficiently? Some things you can measure as successful, like, for example, suctioning an endotracheal tube, maybe. But it's harder to measure that when you're talking about communicating bad news or something like that. So there are difficulties in the definitions. Some of the synonyms in the dictionary, capable, able, proficient, adept, adroit. I don't think I've ever used adroit in a sentence. Expert, skillful. But there's one that really struck out for me, which was trustworthy. And I thought that was interesting. So do you trust me? Maybe that's what it's about. And that's become topical recently. There's an article that appeared in the Journal of the American Medical Association not long ago. And it was a really interesting read. It's written by a doctor whose partner is a doctor. She was pregnant and had some problems with pregnancy, and so was going to go into hospital for an amniocentesis. And the registrar came in. She didn't know it was a registrar. A doctor came in and said, I'm going to be doing your amniocentesis today. And she said, how many of these have you done? And the doctor responded with some deflective statement that didn't answer the question. They had 3 goes at the amniocentesis, struggled, said, oh, there's not a lot of fluid, oh, it's a really difficult one, and eventually they walked out of the room, came back in with what turned out to be the consultant. And the consultant said, look, this happens sometimes, don't know why, but you've had 3 and our limit is 3, so you can't have it today, you'll have to go home and come back. Now obviously that patient was under some stress because of the nature of the problem, so having another week of delay didn't do her any good at all. But in addition to that, she felt betrayed. She felt let down because she wasn't brought into that conversation about how much experience that registrar had had. She felt deceived. And that registrar has got a problem with their perception. I mean, we have to learn these things by experience, don't we? But how do you do that while simultaneously engendering trust in your patients? So this is a topical issue. So let me throw open the question to you. I'm an intensivist. One of my core skills is doing a tracheostomy. If I had to do a tracheostomy on you, what is it that you want to know about me before you are happy to trust me? Has anyone got an answer? Have I ever done one before? Yeah, of course I have. Is that... When did I last do it? Exactly. What's my complication rate? What is my outcome? Yeah. How good am I? Is it enough for me to say to you, I'm a doctor, I'm an intensivist, trust me? But we do that all the time. That's exactly what we do. Do you need to know my complication rate? And that's another hard one, isn't it? Because if I do tracheostomies primarily on bariatric patients, that may be different to somebody who practices in a completely different environment. But is it important that I actually know it? Probably. I mean, if it was being done on me, I'd like to know that the person who was doing it to me took it seriously enough that they know their own results and are self-managing their own problems. What about having somebody oversee my practice? Is it unreasonable for me to expect that the intensivist who sits at the desk beside me in the office comes out once a year, supervises me doing a tracheostomy and says, yes, Todd, you are practicing at consistent, at a standard consistent with current practice? That is what the general public would expect of us, no? I would have thought so. But I wasn't sure, so of course I had to ask the Twitterverse that same question, because that is, the barometer of public opinion nowadays. Interestingly, probably around 50% take an obverse view to you guys. They completely and implicitly trust us to do this because they assume that we do this already. When I've explained the way that healthcare works to lay people, they are shocked by the lack of regulation, particularly if you go and sit down with a group of pilots who are absolutely aghast when you say, this is the way that it works at the moment. If you're learning to do a tracheostomy, we're not going to teach you anything about the tracheostomy beforehand. We're just going to drag you over to the bedside when an opportunity arises. We're going to let you have a go. That's kind of the way that healthcare works. And that level of regulation does not happen is highly controlled in other high-risk environments. The other 50% want us to be more aware of what we do. I think are the two key messages from that survey. So this is another interesting concept. It's trust. So this is a framework called an entrustable professional activity. Has anybody come across this before? No? So it's been talked about in healthcare circles for about the last 10 years. A guy called Ollie Tenkate, who's from Utrecht University, forgive me if I didn't say that right, in the Netherlands, first published about the EPA framework. So there's a lot of problems with competencies. They're very hard to define. It depends on context. It depends on who is providing that. It's very difficult to make a binary decision. Just because they made one minor mistake in their process, does that make them not competent? I don't really know. So to overcome that, the EPA framework's been put in place. It comes back to that concept of trust. So rather than saying you're competent or you're not competent to look after a ventilated patient, how much do I trust you as an experienced person? So when I do my assessment of you, are you safe to do this with me overseeing everything you do? Are you safe for me to check on some of the more complex bits? Or are you safe for me to do it by yourself except in special circumstances? Or are you safe to do it whenever you like? So it's a very interesting framework for doing things. There's a number of different advantages to it. It better defines the scope of practice. So you can say to people, for example, you can look after basic ventilated patients, but anyone who's complicated ventilation strategy, then you need some extra assistance. It's better able to identify the struggling learner. So not everybody gets stuff very quickly. And putting a mandatory number on something is obviously completely arbitrary. You have to look after 6 renal replacement patients before you are competent. What does that mean? That doesn't mean anything. But if you can say, you have now achieved a level of trust where your supervisors believe that you're capable of looking after these patients consistently, is a far better framework for that. They're also repeatable, which means that you can track people's performance over time. And something that I think is really important is that it also helps us overcome the issue with competency-based learning, which is we aim for mediocrity. If you pass the bare minimum standards in a competency-based training framework, you pass. But in this model, you can aim to excel, and I think that's really important. The other one is that it hands over information to the next supervisor. So if you're performing at a certain level which requires a lot of supervision, then everybody around you knows that sort of information. And finally, the really good thing about it is that it helps to define or assess some of those less tangible elements of what we do. Judgment, communication, integrity, professional behaviour, all of those sorts of things that we subjectively make an assessment of our trainees and junior staff members about, but are very difficult to define in a competency-based framework. This is what they sort of look like. I won't bother you with the details, and if you're interested, then I've got the reference for this paper. But this is an evolving topic in healthcare education, and there was a summit on competency-based learning that we presented at in Barcelona just recently, where this was really the hot topic. So I suspect that you'll find that this comes up repeatedly in the next few years. Which then leads me to another topic, which is documentation of what we do. Now, this is my grandfather's watch. I'm proudly wearing it today. He was an Ansett pilot. Does anyone remember Ansett? Speak well of the dead. Ansett was obviously an airline that was pioneered very early on in Australian history. My grandfather was a pilot, one of the original pilots for Ansett, and when he retired and he got this watch, at the age of 67, he'd spent 27 years working for them. And he had the 4th highest number of flying hours of any Ansett pilot at the time, which he was obviously pretty proud of. The reason I'm telling you that story is because he actually knew how many hours he had done, because pilots document everything they do. They know the number of hours that they've flown, they know the number of hours they've flown on one engine, they know how many approaches using a specific technique they do to an airport. Now, when I worked as a retrieval physician and I was doing aviation type duties like being winched, every 3 months I'd need to be recertified on what I did. Every 12 months I'd need to do a full training plan over again, no matter how often I'd done it. And I had to demonstrate both currency, so my knowledge of what I needed to do, and recency of practice. They are two fundamentals in aviation, and it applies to everything that they do, and they document it, and it's checked, and it's legally defined. You can't fly if you're not credited to do so. Take me back to that tracheostomy example again. So I've been doing tracheostomies for 16 years. I was taught well, I believe, by people who are very good specialists. But there's no documentation in existence that I've actually been trained properly. None. I'm allowed to do it to any of you tomorrow, presuming, of course, that you need it. I can do that because I passed my fellowship exam, an exam that did not cover tracheostomy. It assumes that because I passed that exam that I can do it to you, and I can do it safely. In the 15 years since, I have no record of how many I've done. I've got no record of my complications, I've got no record of my ability to upskill, and I've never once been peer reviewed by anybody, ever. That's our baseline in healthcare. But documentation's got an important function, and it comes to the issue of self-evaluation versus self-reflection. It's not immediately obvious what the difference is, but self-evaluation is your ability to understand how you perform. And I hate to say it, but we suck at it. We're terrible when we're not terrible. But we have trouble. And I'll give you an example that was given to me by Marcus Watson, some of you may know, who works at the Skills Development Centre in Brisbane. Put your hand up if you drive. Right up. Keep your hand up if you're in the bottom quartile of skilled drivers in this room. Go on, be honest. So technically and statistically speaking, a quarter of you are in the bottom quartile of skilled drivers in this room. But none of you know who that is. And judging by the number of hands that were still up, usually it's the other way around, but I suspect we're all below average in this room by the looks of things. So we have trouble assessing where we sit. But when we're given credible information about how we perform, we can reflect on that, and that's where we are good. Okay, so the ability to reflect on what you do requires a few things. You need some sort of benchmark, and that needs to be relevant to you. So it needs to be relevant to your practice and what you're interested in and all those sorts of things. And it needs to be objective wherever possible. And it needs to be trusted. You need to believe that that information is legitimate. Otherwise you'll ignore it, because we're all human and we do. It's another way of thinking about data. This is a theory that I've got, and that is that if you are learning to do a procedure, then theoretically you could put on your x-axis the number of attempts that you've had, like the number of opportunities that you get to do that particular procedure. And on the y-axis, presumably you've got a success rate. You're more likely to succeed as you get more experience. Now there's going to be a period where you don't know what you don't know. And so at some sort of inflection point, you'll start to self-regulate your own ability. Now that's a really interesting point, and I don't think we know what that point is. And we arbitrarily put a number of procedures against some of these things sometimes. A lot of the colleges, for example, will say you need to do 10 intubations, but no one knows what that number is. In fact, the colleges don't even know how many procedures their trainees are getting access to, because nobody captures that data. But that's another story. And then after that, you start to get better, because you start to understand your own performance. You know what you didn't do right, so you'll do it better next time. You self-reflect. Now that's another point. So somewhere in between there, people need less and less supervision. Where is it? We're not really sure, but maybe at that bottom inflection point, people are starting to auto-regulate. Maybe they don't need as much supervision at that point. It'd be nice for us to start to define some of those characteristics. And then presumably we'll be able to start putting some confidence intervals around those things. Where should people be performing at a rough stage of their experience levels? And then we can start to see when people do that. Or maybe when they do this, which is something that we don't have good measures of at the moment. So starting to measure what we do may be important to improving our performance. In fact, that's coming out in the literature as well. This came out only a couple of weeks ago. It's a paper that looked at all of the cases where public reporting of outcome data, which is usually surgical because that's easiest to measure, where it's related to outcomes. And what they found is that in almost all cases where people publish their results in a public fashion, their results improve. So by virtue of the fact that we are exposing ourselves to scrutiny, we are improving, which I think is very impressive. Now that's a big challenge. It's very difficult to do. It takes a lot of confidence. And I'm not necessarily standing here saying that we should publicly report all of our data, but maybe there's a step in between. Maybe we should be starting to expose ourselves to our own data in more detail so that we can take responsibility for our own actions. There's a lot of advantages to doing that. Starting to demonstrate that you have got a skill set, and I don't necessarily mean that recording our data is the be-all and end-all. Maybe it's recording that we actually are competent at doing certain skills and not just allowing things to be assumed about us. So we've got the opportunity by recording what we do to set ourselves apart. Maybe take advantage of the opportunity to progress our career based on what we've done in the past. There's maybe another advantage, which is to defend ourselves. You wonder, and I've seen people go through the coroner's court experience and be grilled by experienced lawyers, and lawyers eat healthcare professionals for lunch. They love it because we are just lambs in the wilderness. And I've seen several of my colleagues go through that experience, and it's barbaric to say the least. Some of them have left healthcare altogether after an experience like that. So why do we leave ourselves exposed to that? Wouldn't it be better to be able to say, I've got a record of my training, and stuff-ups happen, they do. People don't always do well. This is a paper that was written by a guy called Rob Solly, who I used to work with, and his mentor, Steve Bolson. Have any of you heard of Steve Bolson? Steve was a whistleblower in the UK. He's an anaesthetist, and he drew to the attention of the authorities that paediatric cardiac outcomes in Bristol about 20 years ago were way worse than what they should have been. And he was pilloried. It was denied. He went to his own college and he reported it. He went to administration and reported it, and he got run out of town. Effectively, he had to move to the other side of the planet to be able to work again. It was horrific. They published this paper on the basis of this about 10 years ago, and they wondered what capturing data about people's performance would do. And they've been capturing it for about 2 years, I think, when this paper was performed. You can see a little incident there at about attempt number 43. So Rob, the anaesthetic trainee at the time, was preparing a patient for cardiac surgery, and they stuck a line in, a neck line in preparation for that, and unfortunately punctured the carotid instead, which happens from time to time. It just does. This was before we used ultrasound routinely. Unfortunately for the lady concerned, she had a stroke, and she had a fairly bad one, and because of her age and comorbidities, ultimately she died. And the family predictably were litigious and were, saber rattling. They had a meeting with the hospital, at which time the registrar had an opportunity to explain his perspective. And because he'd been capturing all of his data and continued to do so after the incident, he was able to put this graph down in front of them. What it is, it's a Q-sum analysis, which is actually a bastardisation of an industry type approach for machinery. So they look at the incidence of faulty pieces being generated from production, and they use that statistical analysis of the number of faulty bits to predict when the machine needs to be replaced. Some people, a guy called Stephen Duckett, who now works down in Victoria, and many of you will know, used this for the first time in healthcare, and it led to that VLAD system that you might remember from a few years ago. But when they applied that same statistical analysis to Rob's procedures, this is what it looked like. Now, if you are consistently trending down like that, that's actually a good thing. That shows that you're continuing to improve your performance over time. So what Rob was able to do is to say to the family, look, I capture all the data about my own performance. I'm serious about patient safety and it affects me greatly. And yes, you can see where your mother was, but you can see that I continue to improve after that. And they immediately withdrew any attempt to sue. They said, we understand that things just happen sometimes. So there's an opportunity to defend ourselves if we use this sort of appropriately. And whether we like it or not, it's coming. So this is a report by a group in the UK called CAMRA. The Medical Board of Australia, which is part of APRA, recently commissioned CAMRA to report on revalidation techniques. The focus of regulation bodies around the world now is about not just what do we know, because we've traditionally focused on CPD type programs, and it's now shifting to what do we actually do. Now, we've traditionally relied on things like, I don't know, you need to have done a certain number of hours or work, what is a minimum number of hours in a year or something like that to maintain your registration. But is that really good enough? Based on what we've talked about previously, probably not. And so the medical board is now starting to look at options for revalidation, and none of them are popular because nobody likes that extra scrutiny. But the results are suggesting, or their preferred response is that we start to look at things like self-audit, 360-degree feedback, patient complaints as measures, global measures of how we're performing. So it's going to come, and it would be much better if we took advantage of the opportunity to shape that for ourselves so that we get the system that we know is going to improve our performance. Now, merging these concepts, it's not that difficult to assume that we're going to be able to demonstrate a capacity set, both as individuals and also as workforces, and that opens up a whole range of opportunities for us. We can identify spots in our skill mix that need work. And an example here from one of the units that we piloted this in shows that they've identified some bellwether type procedures. This is the chart up in the middle there, certifications. And they use that as an ability to track what the percentage of their workforce is capable of doing certain procedures is. And then they can target effectively their training resources. So it makes you wonder why we don't do this already. Other industries do it all the time. Aviation, gas and oil, nuclear, air traffic control, all of these, they have fairly rigid approaches to this. And there are a lot of reasons why that might not work. You know, we're time poor. We're obviously pressed, and we are again at the moment. Relatively transient workforce. We do move around a bit. Particularly in the medical side, during those training years, you know, some of the rotations are only 3 months. But a lot of us move through the system, but we don't seem to be able to take our experience with us, and we should. There's very little dedicated time. When you're a pilot, they just put you offline. But for us, we are not given that opportunity, and it's very difficult to start and stop. You know, we just move on to the next patient or the next patient, and so we don't debrief what we do. We work 365, 7 days a week, 24 hours. We've got fractional appointments. It makes it very difficult to get people in the same place at the same time and train them effectively. We use opportunistic teaching a lot. You can't put a central line in somebody who doesn't need one. And that makes teaching and training about infrequent events very difficult because they just don't come up often enough. There's very little coordination of what a standard looks like. And we do everything in silos. And so we ultimately end up with a whole lot of stuff that doesn't talk to each other. Now, what does a competency mean in one environment when it moves to another environment? It's very difficult. And there's no portability of those as a result. And then, of course, we've got the issue with technology. There haven't been technological solutions to these problems, which is where we believe that Osler comes into it. So in response to all of these issues, I've founded a company called Osler, and we've started to put this across a couple of institutions, including 2 in Queensland. What is Osler? Ultimately, it's an end-to-end certification system. The aim being to provide people with a vehicle to capture data about what they can do, whether that be technical skills, non-technical tasks such as suicide assessment or risk assessment in the emergency department, or falls risk for a patient on the ward, so that those things can be transferred reasonably. What about equipment certifications like we talked about with the transport monitor or the capnograph? And being able to demonstrate that we've got the skills. And there's a couple of people in this room who have had some experience with Osler. And in those environments, we found that people who believed that they knew how to use certain pieces of equipment actually learned a lot by going through a revalidation process. And they discovered functionality that they hadn't even known existed. To make this possible, we've coupled it with immersive multimedia type learning environment. So we provide people with the minimum amount of information that they need to be able to do a skill at the bedside for the first time or in the clinical environment, and then couple that with an assessment framework that works on any mobile device so it can be used at the bedside in the clinical environment for opportunistic teaching, just the way we currently do it, and making sure that those assessments can be done, not just for summative reasons, but for formative reasons, so that we can provide the trainee or the junior staff member with formative assessment and feedback to help them improve their performance next time. And then by doing so, we can create a passport of clinical skills for this person to go forth with. And then to address the issue of recency of practice, they can continue to record information about the procedures and activity that they do using a logbook, again, mobile enabled to make that easy. By doing so, we can start to build up profiles. We can start to benchmark across the cohort that's related to that person. And we can also aggregate that. So as nursing leaders, it might start to act as yet another early warning system. Again, some information from one of our pilot studies where they chose to look at things like, for example, transportation or intubation complications. And they used that as a canary in the mine to detect whether there were issues that they needed to address as part of their training. So let me put this into context for you with an example. Advanced life support is a core skill for, well, all hospitals need to have access to people who are ALS trained. Now, sadly, that certification or accreditation element is poorly defined. If you look at the standards, it simply says each hospital needs to have access to somebody who is ALS trained. Doesn't define what ALS trained is, doesn't define how many people, doesn't define what access means. Is that an hour away? No one really knows. So they leave it up to the hospitals to define what best practice is, which is a cop-out, in my opinion. So this is what we do now. We send people off. The default standard is to go and do an Australian Resuscitation Council course, which, as far as I understand it, is a 2-day course. So we dump a whole lot of information on you and we hope that some of it sticks. We give you some lectures, we give you some part-task training. We do some sort of assessment, usually a plastic dummy in the middle of a table with you and an assessor. That sounds realistic. And then we forget about you for the next 4 years. And we assume that day one after you have completed your course, you'll execute exactly the same as you will day 1264. Now, what it doesn't do is take any account of local policy. It doesn't take any account of whether you can use the equipment that you're going to have to in the environment, and it certainly doesn't take into account whether you've actually done this. So somebody who's doing it once a year will perform completely differently and completely reasonably to somebody who does it every week. And we don't take any account of that at all. Maybe we can do that differently. Within Oslo, we've built this end-to-end process so that you can go through the theory, but not just do it in a dump it all on you kind of fashion, but use it as a curriculum. Provide you with that information, retest, reinforce and so on over a period of time rather than do it as one bulk lot. We can test that just as they do in the ALS course. We can build in local issues such as policy or local equipment and add those certifications into the mix so people can actually use the equipment that they need to. We can also capture things like in situ training such as simulations if that's required. And then we can go on to capturing actual outcomes, so your activity and whether you've been exposed to that process. And then following on from that, we can refresh your knowledge and keep you up to date. Now, one important thing is the exposure tracking. But let's say that you don't have the opportunity to do a resus and you want to upskill and refresh your knowledge, then maybe there's ways that we can help you. And this is an example. So we built this module to be a filler to refresh your knowledge if you haven't been exposed to it. I'll skip through these first 2 slides, but effectively you've got 10 minutes to resuscitate this patient.
Hi, thank goodness you're here. My name is Jo and I'm the nurse in charge. I've got a 75-year-old male who's 3-day post-op TERP. He's used the nurse call bell and we've gone in to see him and he was unresponsive. We've started basic life support. His past history is he's got ischemic heart disease and hypertension. We don't really know what's wrong because his recovery has been unremarkable. So we really need you to come in and take over.
And the next thing you know, you're in the middle of a resuscitation. And you've got a live monitor that's telling you what's going on, you've got a clock running, and you've got a bunch of things that you might be able to do to the patient over here on the left. And some of those include, perhaps calling for some extra assistance. Maybe you'll need to manage your team, tell some of them to speed up, slow down, whatever that might be. But it's the real world. We've got all got access to the flowchart on our crash cart, so we can have a look and see, well, we've got CPR going. The next thing I need to do is assess the rhythm. So I can go back and assess the rhythm. And now I have to make a judgment. I have to apply the knowledge that I've learned in my course and assess the rhythm and make a decision about that. Okay, I'm going to give them a shock, but I've got to do some factory call, which might be to give them a decent dose of electricity. And then things happen in real time. There's no artificiality about this. The time relationship is important. So now that I've done that, I've got a bit of time on my hands. I've got another 2 minutes according to the protocol, but I can't remember what I need to do. So I'll go back and have a look at the protocol. CPR for 2 minutes, Okay, so now I've got to start thinking about some 4Hs and 4Ts. Now, if I'm going to actually rule out the 4Hs and 4Ts, then I need to go digging. Perhaps I need to look at a resuscitation plan and make sure that this is appropriate for me to be doing. I might need to look in the history and see whether there's any reasons that this patient might have had an arrest. Or perhaps I need to go and have a look at their drug chart and make sure that they haven't been given a drug that they're allergic to, for example, which will change the way I do business. If I'm going to rule out a pneumothorax, I'm going to have to listen to the chest. I'm going to have to look at the legs, for example, or to the neck. Is it coming out? Yeah, it is. Looking for physical signs of some of these diagnoses so that I can actively do something about it, because if I don't, then the patient's not going to survive. If I want to know what the potassium is, I'm going to have to order a blood gas. But that's not going to happen straight away. It's going to be at least 5 minutes for it to come back. So I have to think to do it early enough, which tests my ability to pre-plan and preempt. So there's a lot of higher level thinking that's starting to come out in this scenario. Joe's just taking the blood gas now, it's going to run off. It's going to take at least 5 minutes before it comes back. There's a number of other things that I might choose to do, such as putting in a second line. And it will then stagger those things, so I might choose to give a drug, and then I might actually ask her to decompress the chest. But I'm going to overload her very quickly if I'm not careful. So I have to prioritise the actions that are important to getting this patient through. Now, if I do well on this scenario and I stick to the algorithm, so this is designed to test the basic understanding of the algorithm. If I adhere to the algorithm within acceptable margins, the patient will be resuscitated. If not, my supervisor will very kindly come and take over for me, giving me an out. But either way, at the end of that, it's going to be recording all the information about what I'm doing. So if you look at the event log, just as you would in a clinical environment with a scribe nurse, that is a log of the activity that I've done. And if there are things that I can do to improve on my performance, it's going to feed back to me. And this is where that issue with self-reflection comes in. This is undeniable evidence of what I've done. And so I can start to engage with it and buy into how I can do better. At the end of the scenario, I'll actually get a score, so I can compete with myself and I can compete with my mates. And, you know, being healthcare professionals, we're all pretty competitive, like to know that we're doing better than everybody else. And so that's driving our performance and our engagement with the system. And that's what people refer to as gamification of learning. And you can imagine that by going through that sort of process with ALS, we're far more likely to have somebody who's actually proficient in doing so by the end of that pathway. Now, we've had the opportunity to present that at a conference not long ago, which is where I ran into Nick again after several years. But we put this in front of a number of health professionals, many who are very senior like yourselves. There were paramedics there were intensivists, emergency physicians. They all struggled with it. They all did things that went way outside what the protocol suggested was appropriate. They all thought that they knew what they were doing, but they didn't. And it wasn't until they got exposed to that algorithm and that scenario that they realised that they needed to go back and refresh their skills. And that's why this is important. To conclude, this was a slide that was put up at the ME conference in Barcelona not long ago. There was a debate about competency-based training, which was pretty fiery. It was very entertaining, actually. But the very last slide that got put up was the guy who was pro-competency-based training. And this is what he said. Who of you in this room would feel comfortable walking into a room full of people who'd been injured by the healthcare system or their families and saying, we can't change because it's too expensive, I haven't got time, no one did it this way when I was training and I turned out all right. Is it really acceptable that we continue going down this pathway, deluding ourselves that everything's okay, or is it time to take a stand and change? Because the people who achieve highest already look at their performance and try to find ways of making themselves even better. Thank you.